So, approach to intrauterine growth restriction. Let's get to it. Intrauterine growth restriction is a pathological limitation of fetal growth. That's one thing you need to understand. Okay. Intrauterine growth restriction is an important risk factor for pre and postnatal morbidity and mortality. So whether the baby is going to do well or not, intrauterine growth restriction plays a role. It is also a risk factor for atypical child development and adult health problems such as hypertension and diabetes. So as soon as you see that, boom, like it should really come into your mind that, man, if this is the situation and if this is what is being talked about, then I need to really pay attention. Okay. So infants with intrauterine growth restriction, and by the way, when you see IUGR, that's what it means. Infants with intrauterine growth restriction must be distinguished from infants who are constitutionally small for gestational age, but otherwise well. So the whole point about this objective is that while you are learning intrauterine growth restriction, not every baby who is small has intrauterine growth restriction. So you must be able to decipher those who are constitutionally small, but they are okay, from those who have actual intrauterine growth restriction. So let's get into it. So you realize that when you get into every objective, okay, I'm going to show you again. When you get into every objective, there is the key objective, and then there is the rationale and the enabling objectives. And I'm going to show you why I let my lectures go that way. So you realize that they will state the rationale. So intrauterine growth restriction is a pathological limitation of fetal growth. Intrauterine growth restriction is an important risk factor. They will state that, and then they'll come to causal conditions, and they'll go to key objectives. So if you see me quoting these things in the lecture notes, I'm basically picking them from the MCCQE1 objective portal. And then now, based on the information they are giving us, now we are building on it gradually so that you can get the entire concept. Okay, so now, given a pregnant patient, now this is the key objective. Given a pregnant patient with abnormal fetal growth or a newborn with low birth weight, the candidate, that is you, will diagnose the cause, the severity, complications, and will initiate an appropriate management plan. Particular attention. So look, when you are reading the objectives and you start seeing things like that, particular attention should be paid to identification of modifiable risk factors for intrauterine growth restriction early in pregnancy, routine monitoring of fetal growth throughout pregnancy to identify the need for specialized obstetrical management, and careful evaluation of a neonate who is small for his gestational age to detect a possible case of IUGR and assess potential causal conditions. Look, this is a long write-up. So the question is this: how do I break this down? If I'm learning IUGR, what are the things I need to pay attention to? Number one, particular attention should be paid to identification of modifiable risk factors. So that means that as you are learning whichever book or whichever resource you are using, ask yourself, is the resource talking about identifiable, modifiable risk factors? Number two, I should also pay attention to routine monitoring of fetal growth throughout pregnancy. So what are the things that I need to monitor in a pregnancy in which I have identified that this could be a potential IUGR? And then evaluation of a neonate who is small for his gestational age to detect a possible case of IUGR and assess potential causal conditions. So now, enabling objective number one. Let's get into it. Enabling objective number one. So given a pregnant patient with abnormal fetal growth or a newborn with low birth weight, the candidate will, number one, list and interpret critical clinical findings, including recognition of risk factors for IUGR. Boom. So when you are studying, as I said, whichever book you are studying, the first thing you need to note, and please write this down in your workbook right now, in your notebook right now. I need to learn the risk factors for IUGR. I need to master the risk factors for IUGR. If I've not mastered the risk factors for IUGR and know all the risk factors in and out, I've not prepared for IUGR yet. So now I have a question for you. I need somebody to read this question for us. Based on that enabling objective, I want somebody to read this question for us. Please raise your hand, unmute, and let's go.
You are running a high-risk pregnancy clinic. You review a 32-year-old G2P1, Gravida 2, Sarah 1, at 32 weeks gestation. Patient's abdomen measures in the 5th percentile for gestational age. What risk factors will you inquire about?
Beautiful. The reason why I set this question is because it is in the enabling objectives. So it's in the enabling objectives. So please kindly jump onto it. If you can't answer this question, that means you've not prepared for this objective well. You might have read IUGR in whichever book, be it Toronto Note, Master the Boards, whatever. But if you've not nailed it, if you've not learned risk factors, at least 10 risk factors off head, and when you're learning the risk factors as well, remember the main objective was talking about modifiable risk factors. So you have to ask yourself, with all that I'm learning, what are the modifiable ones among them? Let me see what some of the doctors are writing. So Dr. Cosmos said nutrition. Dr. Cosmos, I will not go with that. Nutrition. What kind of nutrition? Bad nutrition, good nutrition, smoking, alcohol use, type 1 diabetes. Sure, those three are powerful. Oh my goodness, Dr. Root just type something. Prior history of IUGR. In fact, prior history of IUGR is the highest risk factor you can ever think about. So when you are, so Dr. Root, that is very, very good. I'm very, very impressed by that. You just wrote that, bam! Then Dr. Maria said, hypertension, diabetes, previous pregnancy history. Dr. Maria, I will take 2. I will not take the previous pregnancy history. I don't understand what previous pregnancy history is all about. Maybe you wanted to say previous history of IUGR. So make sure that you state your answer. Low maternal, according to some other doctor. And then others are also going to nutritional status. Dr. Froza, I will not take nutritional status. Previous IUGR, please. Now let's get into it. So I've seen a lot of the answers. Anemia in pregnancy, Dr. Kano, poor nutrition, CPD. What's CPD? Cephalopelvic disproportion? No. Okay. So when it comes to the risk factors for IUGR, you have to know that there can be fetal genetic abnormalities in genetics about the fetus itself. And then number 2, you can have fetal infection. Please write these down. Write them down. Please write them down. Fetal infection. And when I say fetal infection, cytomegalovirus. Now, even with a fetal infection, remember that I can set a whole question around fetal infection so far as IUGR is concerned. And I can say that you are evaluating a patient who is pregnant and who is a newcomer to Canada. It changes the whole game. And this patient is 32 weeks. The patient just arrived in Canada about a week ago. You are reviewing possible infections which can cause the condition. What is the most likely condition you should start thinking about? Even though here I've stated cytomegalovirus and toxoplasmosis, remember that it is the most common in developed countries. Now, if I say the patient recently came to Canada, the patient was pregnant before the patient came to Canada, then malaria is one of the things you want to think about. In fact, malaria and Zika virus. So remember, we are talking about fetal infections that can lead to IUGR, cytomegalovirus and toxoplasmosis. But remember that cytomegalovirus and toxoplasmosis are most common in patients in developed countries. Malaria is more common in patients from endemic areas. So if you are told that the patient is coming from sub-Saharan Africa, you know, like areas where there's malaria, then think about that. Then it could also be a fetal structural anomaly. Then it could be multiple gestation. Please, doctors, we are reviewing risk factors for intrauterine growth restriction. Kindly take note of this because this is a major enabling objective. And what is multiple gestation a risk factor? Number one, you know that the uterus is limited. And so if there are two people occupying that uterus, or if there are 3 or 4 of them, then at times there's inability of the uterus and the placenta to meet the nutritional needs of the multiple babies. Doctors, please, are we all tracking together? So someone might ask you, why is multiple gestation a risk factor for intrauterine growth restriction? Because maybe the uterus cannot, support more than one fetus. Number 2, complications of multiple gestation. Because multiple gestation at times predisposed to preeclampsia, twin-to-twin transfusion syndrome, selective fetal growth restriction. So that's also a very critical point. And it could also be that because of the multiple gestation, there's placental and umbilical cord abnormalities. For example, velamentous cord insertion. So these are the reasons why a patient with multiple gestation can have a baby with IUGR. And it could also be that the blood flow to the placenta itself, ischemic placental disease, the blood flow to the placenta itself has some issues. Examples in cases of preeclampsia, examples in cases of placental abruption, example in cases of abruptio placenta itself, and even stillbirth. So some doctors are still joining from the Facebook group. That's why at times I look sideways, just to make sure that they're also taken care of. Then we are still on the risk factors. Cord and placental abnormalities. Doctors, as we state these risk factors, I want you to note which ones are modifiable risk factors. Please write them down. As we go through all these risk factors, ask yourself which of them are modifiable risk factors. So single umbilical artery, is this a modifiable risk factor? I don't think so. The mother cannot do anything about it. Velamentous umbilical cord insertion, marginal cord insertion, so an umbilical cord which inserts on the margin of the placenta. Bilobe placenta, the mother can't do anything about it. Circumvallate placenta. What I would suggest is that when the class is done, take your time, go on Google and look at pictures of all these types of placenta. Placental hemangioma. And then maternal genetic risk factors. Did you know that if this patient herself, when she was developing in her mother's uterus, if that patient herself also had IUGR, then there is 2-time increased risk for developing fetal growth restriction in their offspring. So please, especially for those who are taking the exam from next year, April 2025 onwards, remember that now the exam is going to change from MCQ and CDM to MCQs alone. That means when you are learning these concepts, you must be very sharp on it. So number one key home point you need to know is that if mother had growth restriction herself, she has an increased likelihood of having a baby with intrauterine growth restriction. And previous fetal growth restriction increases the risk of further growth restriction. And that's what I said. Usually the statistics tells us that there's about a 25% risk that if a patient has or gave birth to a baby who had intrauterine growth restriction, there's a 25% risk that the baby can also have intrauterine growth restriction. Then preeclampsia is also one of them. Placental abruption is one of them. Chronic hypertension. Doctors, please, as we go through these, can someone tell me which of these are modifiable risk factors? Because the enabling objective was talking about modifiable risk factors. So of all these risk factors we are talking about, which of them is a modifiable risk factor? Pre-gestational diabetes, systemic lupus erythematosus, antiphospholipid syndrome, cyanotic heart disease, chronic pulmonary disease, severe chronic anemia. I'm very happy people are really paying attention. Sickle cell disease, uterine malformations, misuse of alcohol, misuse of cigarettes, misuse of other drugs like heroin and cocaine. At least I know that that is a modifiable risk factor. At least I can tell that that is a modifiable risk factor. All right. So please, as we are going through it, pregnancy radiation therapy to the pelvis. Yes. That's a risk factor which can be modified a little bit. You can delay the exposure of radiation to the pelvis when the patient is pregnant. Heavy first trimester antepartum bleeding. That's not a modifiable. Previous small for gestational age newborn and previous stillbirth. Previous stillbirth is not a modifiable risk factor. Previous small for gestational age is not a modifiable risk factor. Great, Dr. Enrique has been writing the modifiable risk factors in the Facebook group, and that's powerful. So, doctors, please, other risk factors: assisted reproductive technology. Okay, low pre-pregnancy weight in the mother herself, poor gestational weight gain, malabsorption, poor nutritional status. So, doctors, are you realizing why I was telling those who just wrote nutrition that is wrong? You should rather be specific. Poor nutritional status, staying in high altitudes. So, like, patients who live on mountain tops, right? And then short intervals between pregnancies. And then extremes of maternal age. So if the mother is very young or if the mother is very old. So doctors, before I move on, I really want us to grasp this concept very well. Can somebody tell me at least 6 risk factors for IUGR before we move on to the next objective? 6 risk factors for IUGR. Can somebody just quickly summarize it for me? 6 of them. Just quickly, doctors. Dr. Yvette, let's go. Please start rattling it. Risk factors for IUGR.
Okay. Okay, we can group them into fetal and then maternal. So under fetal risk factors, we can think of fetal structural abnormalities such as those syndromes like Edwards syndrome, Patel syndrome. Also, we can look at placenta, like the placenta. So there can be placenta previa and any placental insufficiencies.
Yeah.
And then maternal, we can look at if the mother has a previous history of intrauterine growth restriction, if the mother has diabetes, if the mother has hypertension, if the mother herself when born had intrauterine growth restriction, the use of alcohol, misuse of alcohol, drugs, poor nutritional status of the mother, among others.
Yeah, at least that's very good. So when you go through it this way, that's so now when you're learning intrauterine growth restriction, you don't want to rush over risk factors for IUGR. Very, very important, please. Okay. Now, in relation to the risk factors, I put out this question. Can somebody read this question for us? Because there are drug risk factors as well. So I just put this out. Can somebody read this for us, and then all of you can put in your answers for me?
You are running a high-risk pregnancy clinic. You review a 32-year-old G2P1A0 at 32 weeks pre-gestation. Patient's abdomen measure is 5th percentile for the gestational age. You want to find out about medication the patient's taking. Which medication is not noted to cause the fetal growth restriction? Select the most appropriate.
Beautiful.
Choices are cyclophosphamide, cisplatin, valproic acid, methotrexate, acetaminophen, and warfarin.
Beautiful. Beautiful. Thank you very much. I'm very happy about the way you read the case. So,
Thank you.
yeah. So, and I really like the way you put a lot of effort. Which medication is not? By the way, doctors, please remember that in the MCCQE1, you have 1 minute, not more than 1 minute, 10 seconds to answer every MCQ. Not more than 1 minute, 10 seconds to answer every MCQ, right? So let's get into it. So which of these medications do you think is not noted to cause fetal growth restriction? Let me look at the answers. Oh my goodness. It looks like E is the favorable answer. For example, acetaminophen. And that was easy. That was easy. Acetaminophen is a medication we all use for our headaches, our joint pain. So now this is this is another thing. We're talking about, risk factors for IUGR. You also have to learn the drug risk factors for IUGR because they are all part of the risk factors, right? One drug which can lead to IUGR is warfarin. Another drug class is anti-seizure medications like valproic acid. Another drug class is anti-neoplastic, anti-cancer agents. And I've listed quite a number of them. One common one is cyclophosphamide. Another one is platinum coordination complexes like carboplatin, cisplatin, oxaliplatin. Okay, so all the tins, platin. So if you hear platins, know that they go with IUGR. Platins go with IUGR. And then folic acid antagonists. Remember that fetuses need good maternal supply of folic acid so that their neural tubes are developed well. So if the mother has, an issue with folic acid deficiency or whatever, that can lead to IUGR as well. And patients who take tobacco, marijuana, alcohol, and patients who live in places with air pollution, and patients who have radiation therapy as well. So I'll keep the thing here. You can take a screenshot or whatever you want to do. Just make sure that you write, some medications which can lead to IUGR. And don't forget that common things are common in Canada. If I was supposed to learn these medications, I'll learn warfarin, I'll learn anti-seizure medications. I like valproate because we have quite a number of people with seizure disorders. I will learn alcohol, tobacco, warfarin, marijuana. Okay, and then maybe I'll come here, I'll learn some trimethoprim, sulfamethoxazole. I will learn some proguanil because, at times patients want to travel to malaria endemic areas, right? So I'll learn these things. Okay, good. Doctors, please, before we move on to this, is that okay with what we just did? Is that okay? I want to know, is that okay? Did we break down the medications well? Risk factors, we are still on risk factors because risk factors is very big for this particular objective. Good. Dr. Freddy says, good. Okay, good. So now let's go to another one. I want somebody to read this question as well for us.
You are running a high-risk pregnancy clinic. You receive a 32-year-old G2P1A, a 32 weeks gestation. Patient's abdomen measure in the 5th percentile for the gestational age. You requested blood work for the patient. Which labs are you likely to notice? Choose as many as apply.
Now, yeah, okay, good. Please continue.
Low pregnancy-associated plasma protein, A. B. High pregnancy-associated plasma protein, A. C. Low beta human chorionic gonadotropin.
Yeah.
D. High beta human chorionic gonadotropin. E. low alpha fetoprotein, F, high alpha fetoprotein.
Beautiful. This is a CDM case I've crafted for you based on risk factors, based on possible laboratory findings in patients with IUGR. Now, the way the question was crafted, it says choose as many as apply. In a CDM, when you see choose as many as apply, it can be that there's only one correct answer. It can be that there are multiple answers. So let me see what the doctors are writing. Some are going with ACE. Okay, I'll come to Dr. Shale, I'll come to your question, okay, please. No, let's finish with this and then we go. So, what is the answer? So the one who said ACE, it's rather ACF. ACF. In a patient with IUGR, it's not every baby with IUGR or every patient with IUGR who will have these labs. But if you are looking for labs which are likely to be seen in a patient with IUGR, then look for low pregnancy-associated plasma protein A. Number 2, low beta HCG. And number 3, high alpha fetoprotein. So know which ones are low, know which ones are high. And I've developed a whole slide on it so that you can use this to remember which lab values are low, which lab values are high. Low pregnancy-associated plasma protein A, that is low. Beta HCG will be low, but alpha fetoprotein will be high. Doctors, please write this down. Write it down. I don't want to move without you writing it down. Write it down so that you know, okay, hey, which labs should I expect? Which labs should I expect? Which labs should I expect? Now, Dr. Sahil asked the question, Dr. Bruni, in fetal infections, can we write torch infections or do we have to write each component of torch in separate lines? Now, Dr. Sahil, if, for example, you have other options, like other options you've written, which are also correct, then maybe you can write torch infection. But if you have run out of options, then I will suggest that you go with T for toxoplasmosis, C for cytomegalovirus, so that you are covered as well. So it all depends on your situation in the exam. If you have, you've written other options which are correct, then you can write torch infection as one line. But if you are still struggling for options, then what you want to do is, then the wild thing to do is to break them down. Okay, to break them down. Okay. Doctors, have a question. How is class going for you? How is class going for you? If it's going well, just type yes, yes, yes. By the way, can somebody share what they've learned so far? The way we are going with objectives, is it opening your eyes to certain things? Is it opening your eyes? If yes, let me know. What is it opening your eyes to? Because, as I said, you can easily say, oh, I've finished IUGR. Boom. You go into the exam, you realize that no, you've not really finished the IUGR. So, will somebody want to share what they are realizing? Like the way they've been studying and the way class is going. What is coming out for you? Share. Don't worry, just share. We are all in a studying environment. Will anyone want to share some? Dr. Monday, please unmute yourself and share.
Okay. I'm so happy about the course because it enabled me to know where to focus on. Understand? Because you have a lot of resources over there, but you get confused of where to start, or you try to close the whole, finish all the whole medical books before you know that you are ready for the exams.
Mm-hmm.
So the course actually opened my eyes to know where to focus, right, and what to look for in those available materials I have, not to finish the whole gynecology, for example, before I'm ready. but
Just
to focus on the topics by topics.
Yeah, it's just a waste. As I said, you can pick the popular books people talk about, and you can read them. Not everything under those systems are relevant for them. No.
Okay.
But so you see, if I were you, I'd rather focus my attention on IUGR and make sure I've mastered IUGR in and out, rather than say, oh, you go to group study. Oh, today I finished the whole of obstetrics. Meanwhile, maybe the objectives in obstetrics may not even be up to maybe 10 topics.
Okay.
That's the problem. But let's go on.
Yeah. You keep on wasting much time.
Exactly.
Okay. Yeah.
So you are running a high-risk pregnancy clinic. You review a 32-year-old gravid at 2.1 at 32 weeks. The patient's abdomen measures in the fit percentile for gestational age. You make a diagnosis of IUGR. Which other conditions are associated with IUGR? That's another one. Which other conditions are associated with IUGR?
Low birth weight.
Oh, low birth weight, of course. We know the patient has IUGR, therefore there will be low birth weight, okay? So that's good. But then it is obvious, right? Low birth weight will be obvious. Yeah.
Congenital syndromes, maternal infection, and
congenital disease.
Metabolic, like maternal medical condition like hypertension, PIH, hypertension.
Oh, maybe, sorry, maybe wait. Maybe I've made a mistake. Let me, in order for you not to get confused, let me just state it this way. Let me just clarify the question, because I think I get where you're coming from. In the fetus, let me say in the fetus. Okay, which other conditions are associated with IUGR in the fetus?
Neural tube defects.
Congenital heart disease.
Congenital heart disease. What else?
Edwards syndrome, fetal
And
syndrome,
the
diabetes, gestational. Fetal diabetes.
Yeah. Okay. So what are the associated conditions with IUGR? Omphalocele is one of them. Number 2, gastroschisis. Number 3, diaphragmatic hernia. Number 4, skeletal dysplasia. Please write them down. Number 5, congenital heart abnormality. So I think somebody mentioned that. Number 6, congenital portosystemic shunt. And all those other ones, Pato, Edwards, Downs, they are also associated as well. Because we learned that if there is a fetal genetic abnormality, so like Down syndrome is like trisomy 21, right? Yeah, Down syndrome is also associated with it. So while you're learning your Down syndrome, Pato, Edwards, please don't forget omphalocele. Don't forget gastroschisis. And these are issues with the anti-abdominal wall. Don't forget diaphragmatic hernia. Don't forget skeletal dysplasia. Don't forget congenital heart abnormalities. Don't forget congenital portosystemic shunts as well. All right? Good.
Sorry, can I ask a question quickly, please? I don't know. Yeah, this associated confusion with IUGR, it can, I'm looking at it from another angle, like the causes of IUGR, like what could lead to IUGR, are they also these associated conditions or the abnormalities that are associated with
this can be associated with IUGR as well. So these can be risk factors for IUGR, and then these can also be considered as associations with IUGR. So in other words, when you have a baby with IUGR, what are you also likely to see in the baby? Right? Yeah.
What about this condition of meconium, like when the meconium is few, like?
So you're talking about oligohydramnios.
Oligohydramnios, yes. Hydramnios.
Most of the time, IUGR is associated most of the time with polyhydramnios. Most of the time.
Polyhydramnios, okay.
The reason is, let me give you an example. For example, you know that the children at times swallow the amniotic fluid, right? Now, if the kid has like gastroschisis or omphalocele, like the intestines and the rest have already come out. So the regular and the normal function of the GI tract is not in a good shape, and you're expecting this child to be swallowing at times, there's some part of the amniotic fluid. So you realize that then the amniotic fluid will build up. So that's why I'm saying that polyhydramnios is rather associated with IUGR more than oligohydramnios. Okay. Okay.
Thank you.
This is a teaching point I want to give. Which category of patients should get genetic testing done when diagnosis of IUGR is made? So, sure, Dr. Maria, that's fine. Yeah, hypertension can lead to oligohydramnios. That's noted. Which category of patients should get genetic testing done when diagnosis of IUGR is made? Look, in your exam, it's not everything that you just go like, yeah, the patient needs genetic testing, especially in Canada. When there are situations which should cause you to say that, okay, I'm going to do genetic testing in this particular patient. And what are some of them? Number one, and I've listed some of them. Fetal growth with IUGR before 32 weeks in the absence of an identifiable non-genetic cause of growth restriction. So when you've looked at all the possible causes of IUGR, especially genetic causes, and you don't find any, and this child's IUGR or this pregnancy's IUGR was diagnosed before 32 weeks, that is one reason why you may want to do genetic testing. Number two, if there's IUGR plus major fetal structural abnormality, so these patients we talked about, skeletal dysplasia, omphalocele, gastroschisis, IUGR with congenital heart disease, you want to do genetic testing. Number three, IUGR plus ultrasound features associated with genetic abnormality, like a thickened nuchal cord, nuchal fold in Down syndrome. So if you suspect that this baby has IUGR and your ultrasound features are pointing towards a particular genetic abnormality, then you want to do genetic testing. Then fetal growth restriction plus polyhydramnios, you want to do genetic testing. And ultrasound findings suggestive of triploid pregnancy, so whatever triploidy you are concerned about. So these are some of the indications for genetic testing. Let me say it again. Genetic testing in a patient with IUGR. Indications. You have to know them. You have to memorize them. You have to write them down. Now, if you have a patient with IUGR, what further workup will you do? You want to do amniocentesis for PCR of amniotic fluid for cytomegalovirus. I have a question. I stated this initially. Which group of people are you going to? Okay, if you have a patient who is from the US, or who is from Great Britain, or who is from France, who came to Canada, who has IUGR, and you are thinking this could be because of a maternal infection, which two infections are you going to think about? Please, can somebody remind me? Which two infections are you going to think about?
Cytomegalovirus and
Virus.
Toxoplasmosis.
And toxoplasmosis. Okay. What about if you have a patient coming from Brazil? What infection are you going to
Brazil.
Zika.
Zika.
Malaria.
Beautiful.
Malaria.
And Zika. Beautiful.
Zika.
So you want to do amniocentesis for PCR of amniotic fluid for cytomegalovirus, especially in patients coming from well-developed countries, and then malaria test for patients who live in endemic areas, and Zika test in patients who live in endemic areas, and you also want to screen for syphilis, because congenital syphilis can also lead to IUGR. Now, assuming I was quizzing you, and I threw in that part of your workup, you just do regular antiphospholipid antibodies. What you tell me is that, no, Dr. Brony, no. I am not going to do routine testing for antiphospholipid antibodies when a patient has IUGR. I will not do routine testing for antiphospholipid antibodies for IUGR. Let me say it again. I will not do routine testing for antiphospholipid syndrome, antiphospholipid antibodies in the case of IUGR. If the patient is coming from a developed country and I'm thinking it's an infection, I'm going to screen for toxo, I'm going to screen for cytomegalovirus. If the patient is coming from a malaria endemic area like sub-Saharan Africa, I'm going to screen for malaria. If the patient is coming from a place where there's likelihood of Zika virus, I'm going to screen for that. One other thing I'm not going to forget is syphilis. But for antiphospholipid antibodies, I'm going to be careful. Doctors, are we all on the same page? Please. Can I move on to the next line of action?
Please, can you quickly point why antiphospholipid antibodies in the first instance?
Patients with antiphospholipid antibodies, there can be a lot of complications in pregnancies. For example, number one, they can have recurrent pregnancy losses, right? Number two, they can have deep vein thrombosis in pregnancy. They can have pulmonary embolism in pregnancy. And at times, that can also lead to IUGR. However, don't do antiphospholipid antibody testing routinely in a patient who has IUGR. That's all I'm saying. Antiphospholipid syndrome is very, very important. It's something you need to really know, especially if you have a patient who has recurrent pregnancy losses. However, don't do testing for antiphospholipid antibody routinely in a patient who has developed IUGR in this pregnancy. Next enabling objective. List and interpret critical clinical findings, including routine monitoring of fetal growth through physical exam. So as I said, never say you've reviewed IUGR unless you've ticked all these boxes and you've reviewed all these lines. So how am I going to monitor a patient with IUGR? We need to do regular SFH measurements. When I say SFH, what I mean is symphysiofundal height. So symphysis, so if you see my mouse, the pubic symphysis to the fundus of the uterus. So you're going to monitor that routinely, and then you're going to correlate that with gestational age. If you have a patient with IUGR, that's what you're going to do. SFH measurements will have to be done, regularly, and then you want to correlate that with gestational age. Now, what if the mother is a high risk for what if the mother is a high risk for IUGR, or the SFH is lagging more than 2 centimeters behind the gestational age? Then you want to go ahead and do ultrasound for biparietal diameter. Okay, ultrasound for biparietal diameter. Ultrasound to assess the head of the baby, to assess the abdominal circumference, to check the fetal length, to check the fetal weight, to check for amniotic fluid volume. And you also want to assess whether there's any decrease in the rate of growth of the baby. And you want to check the biophysical profile of the baby. And you want to do Doppler analysis of the umbilical cord blood flow. So please, what are the monitoring modalities you want to do in a patient with IUGR? Number one, I'm going to monitor the symphysiofundal height regularly. This one, I'm going to keep monitoring it. Then number two, I'm going to do serial ultrasound for the biparietal diameter, for the head, for the abdominal circumference ratio, head to abdominal circumference ratio, for the fetal length, for fetal weight, for amniotic fluid volume. Then I'm going to check regularly if there has been any decrease in the rate of growth. And I'm going to do biophysical profile. And I'm going to do a Doppler analysis of umbilical cord blood flow. Doctors, can I move on? Write them down. The IUGR is finicky, right? So please write them down so that you can use that to memorize. And don't forget that I'll also be sending you the replay as well. Okay. So now another enabling objective. List and interpret critical clinical findings, including evaluation of low birth weight infant to determine whether the case is one of IUGR or a neonate who is constitutionally small for its gestational age. So this is very important because not every baby who is born who is small has IUGR. Some babies who are born small, we call it constitutionally they are small because it could be that their mother is small, right? And it's just a genetic thing. Paying particular attention to features on history and physical exam that are indicators of potential causal conditions. So, how to detect, how will I know? Number one, if they are modestly small. So, if their estimated weight is between the 5th and the 10th percentile, that should not cause so much alarm. Number two, even though they are small, you realize that they have normal growth velocity, right? They are small, but then they are growing like normally, so far as how the fetus should grow is concerned. Number three, if they have normal physiology, for example, if the amniotic fluid is normal, amniotic fluid volume is normal, if the umbilical artery Doppler is normal, then it could tell you, oh, okay, this could be a constitutionally small fetus. If the abdominal circumference growth velocity is above the 10th percentile, and if they have appropriate size in relation to the maternal characteristics, so like you look at the mother herself, the mother is small, and the fetus is also looking small, abdominal circumference growth velocity is above the 10th percentile, normal amniotic fluid volume for that size of the mother, normal growth velocity across gestation, then you can say that, okay, this fetus looks like a constitutionally small fetus. But that does not mean that that fetus has IUGR. So doctors, please, this is also very important because the objective says you should know it. How am I going to evaluate a baby who is small? How will I say that this baby has IUGR, or how will I say that this baby is constitutionally small? And these are the things you have to look out for. Modest smallness. If the baby is between 5th to the 10th percentile, well, normal growth velocity across gestation, normal physiology, where there's normal amniotic fluid volume, normal umbilical artery Doppler, abdominal circumference growth velocity is above the 10th percentile, and appropriate size in relation to the maternal characteristics.
Yes.
So today we've learned
Yes, you can.
how to distinguish between constitutionally small fetuses, because if you have a baby with IUGR, most of the time, the weight may be below the 5th percentile. You realize that their growth velocity is not normal. You realize that they may have polyhydramnios. You realize that umbilical artery Doppler, there may be some abnormalities around. You know, the way blood is flowing through the umbilical cord. You realize that maybe the abdominal circumference growth velocity is not very good. And you realize that maybe the mother is a normal sized female, but this baby is very, very small. Okay. So let's go to the next objective. List and interpret critical investigations, including indications for pregnancy investigations to assess fetal growth and well-being. And we learned that we are not going to do routine antiphospholipid syndrome tests, right? And we've talked about a lot of these already. Like with this particular objective, we've already dealt with it, where we talked about the investigations we are going to do, the CMV, the amniocentesis for CMV, the serial symphysis height measurement, the biophysical profile, the serial head measurement, the serial abdominal girth measurement. So I'm not going to waste your time on that. Okay. Now, what are the indications to assess fetal growth and well-being? Number one, diabetes in the mother. Number two, the mother has hypertensive disorders. Number three, fetal growth restriction, right? Number four, twin pregnancy, because we said twin pregnancy can predispose to preeclampsia. Twin pregnancy itself can also predispose to IUGR. Then post-term pregnancy. Then decreased fetal activity. Then that one, you are very wild. Hey, I need to monitor fetal growth and fetal well-being. And if the patient or the mother has SLE, systemic lupus erythematosus, then you're also going to assess for fetal growth and fetal well-being.
Hello?
Yes, please, ask your question. That's fine.
What about genetic, or like in blood group? The mother is like negative, and the father is positive.
You've not finished. This is it. Immunization to the red blood cell antigens. Right?
Oh, okay.
Then genetic conditions like if the mother has sickle cell disease, antiphospholipid syndrome, oligohydramnios, polyhydramnios, prior death of a fetus. So if, mother has had prior death of a fetus, and then mother goes on to have a pregnancy where the baby is measuring just about a 3rd percentile, then you want to do further assessment of fetal growth and well-being. And preterm labor, rupture of membranes, then you want to go on to do assessment of fetal growth and well-being. So now it brings us to the types of IUGR. We have symmetric IUGR and asymmetric IUGR. Symmetric IUGR and asymmetric IUGR. So this is a baby who has appropriate growth profile. This is a baby who has symmetrical IUGR. When we say symmetric IUGR, what we mean is that the rate of growth of the head is similar to the rate of growth of the entire body. Now, in symmetric IUGR, like the baby is small, right? But then you realize that both the head and the body is small. But in asymmetric IUGR, you realize that the head is normal, but the body is small. I have a question for you. Doctors, if you were supposed to choose between symmetrical IUGR and asymmetrical IUGR, which one will you choose? Like, which one will have a more favorable outcome?
Asymmetrical.
Asymmetrical.
Symmetrical.
Okay. Now, since you said asymmetrical, I have another question for you.
Asymmetrical.
Symmetrical IUGR and asymmetrical IUGR, which of them do you think starts very early in pregnancy? And which of them do you think comes on late pregnancy?
Symmetrical.
Starts earlier. Symmetrical starts
Symmetrical.
earlier.
Symmetrical IUGR.
Okay, so
starts at
please, so many of you are
pregnancy.
speaking. Which one starts early? Let's start with the early one. Which of them is likely to be as a result of an early issue in pregnancy?
Symmetrical.
Symmetrical. Beautiful.
Symmetrical.
And which of them is as a result of maybe a late issue in pregnancy? Asymmetrical. So
Asymmetrical.
today we are learning two things. Number one,
Asymmetrical.
symmetrical may be as a result of maybe a genetic abnormality. So like it's just going on throughout the pregnancy. Asymmetrical, the brain is already developed. So that is a very good one. And if I have a child with symmetrical IUGR and asymmetrical IUGR, likely that the one with the asymmetrical IUGR may have a better outcome. So symmetric IUGR, the brain is in proportion with the rest of the body. So the body is small, the brain is small. Occurs before 20-week gestation, usually as a result of genetic issues and fetal infection, right? That's symmetric. Asymmetric, the brain weight is not decreased. The abdomen is rather smaller than the head. Usually occurs after 20 weeks. And it is affected by, it is caused by extrinsic factors. Example, uteroplacental insufficiency. Let me stick it again. Symmetric versus asymmetric. Likely that a child with the asymmetric IUGR may do better than the one with the symmetric IUGR. Symmetric IUGR, the brain is small, body is small. Asymmetric IUGR, brain is normal in size, body is small. Symmetric IUGR usually occurs or is as a result of factors which are affecting the pregnancy prior to 20 weeks. Asymmetric IUGR, usually factors which are affecting the pregnancy after 20 weeks. Clinical peril. IUGR from intrinsic factors like aneuploidy, congenital malformations, or infection carries a guarded prognosis, not very good. That often cannot be improved by any intervention. IUGR related to uteroplacental insufficiency. Uteroplacental insufficiency, is it going to cause symmetric or asymmetric?
Asymmetric.
Okay, so
Asymmetric.
related to uteroplacental insufficiency has a better prognosis, but the risk for adverse outcomes remains increased. So we've learned symmetric versus asymmetric. which one has better outcomes, which one has poor outcomes, which one is likely to start before 20 weeks, which one is likely to start after 20 weeks. So listen, interpret critical investigations, including indications for pregnancy, investigations to assess fetal growth and well-being. We've done all this. Indications for neonatal investigations for causal conditions. We've already done this, but I want to repeat it again. Investigations for patients with IUGR. You want to do monitor the fetal weight, where you do estimated fetal weight, which should be monitored every 2 to 4 weeks. Number 2, Doppler velocimetry, okay, Doppler ultrasound, umbilical artery Doppler. Remember that we said that a constitutionally small baby, the umbilical artery Doppler will be normal, okay? The middle cerebral artery pulsatile index. So there's the middle cerebral artery in the brain. In IUGR, especially if it's as a result of uteroplacental insufficiency, look at what is going to happen. Uteroplacental insufficiency, there is less oxygenation from the mother to the baby, okay? So assuming you have this middle cerebral artery, are you going to expect blood flow to be high in the middle cerebral artery or to be low? It will be high. Why? The reason is because the baby is not getting enough oxygen from the mother. The body is going to compensate by causing more blood flow so that it can get enough blood to the brain. So in a baby with IUGR as a result of uteroplacental insufficiency, you realize that blood flow through the middle cerebral artery is very high. And then you also want to do a biophysical profile and non-stress test, as well as a cardiotocography. Okay, so please, these are the things you want to do for a patient who has IUGR. One thing you don't want to miss is middle cerebral artery. The pulsatile index, will it be high or low? In a child or in a pregnancy which has uteroplacental insufficiency, middle cerebral artery pulsatile index will be very high because the body is trying to compensate for the lack of oxygen by getting more blood to the middle cerebral artery. Okay, so construct an effective initial management plan, including referral of the patient for specialized obstetrical investigation and management, if indicated, and initiation of resuscitation of a distressed unit as required, and referral for specialized pediatric care and developmental surveillance in the case of IUGR, and counseling and education of a patient regarding high-risk factors management and sequelae of IUGR as appropriate. I'm not going to waste your time on this, but we're going to keep it very simple. Management of IUGR, it must be prevented through risk modification. Remember that when we're starting the class, one of the main objectives was for us to learn the modifiable risk factors and know how to deal with them. So in the management of as well, you want to teach the patient on prevention through risk factor modification. Because we also learned that if this patient has had a previous pregnancy where the fetus had IUGR, there's a likelihood that future pregnancies may also have IUGR. However, if this IUGR was as a result of a modifiable risk factor like smoking, like alcohol use, like, illicit drug use, like even poorly controlled diabetes, poorly controlled renal disease, poorly controlled hypertension, then I know that if I control that risk factor, then chances are that the future pregnancies can be protected. Number 2, modify controllable factors like smoking, alcohol, nutrition, and treat maternal illness, like diabetes, like hypertension, and all those things. And then serial biparental BPP, where you use that to monitor fetal growth and determine the cause of IUGR if possible. And then now, we move on. Delivery when extrauterine existence is less dangerous than continued intrauterine existence. Okay, if when you deliver the baby will do better than the baby still being in the mother's uterus, then you want to deliver. Then optimize fetus with magnesium sulfate for neuroprotection. Early GBS swab and pediatrics consult if that baby has to be delivered. So if there's a baby with, if the mother has IUGR and you think that this baby needs to be delivered, then you want to get a pediatrics consult in. And this baby may need to be delivered by cesarean because you don't want to put the baby through the hustle and bustle of spontaneous vaginal delivery. Doctors, how was this like? Sure, please ask a question. Please ask a question.
Okay. While we were discussing about modifiable risk factors, although we said conditions like congenital heart disease, like these omphalocele gastrocrisis, that they are not modifiable. However, I have heard that the major reason why patients developed such congenital heart disease and all those central line defects are also as a result of lack of vitamin B, folic acid rather, and pregnancy prevention, malaria prevention. So, and in our discussion, you also talked about malaria. Actually, malaria as one of the causes in sub-Saharan Africa. So, in terms of prevention, I believe one of the strategies that we use to prevent in my center is we do use early, because we want to start the patient, the mothers, before they get pregnancy. We want to start them on folic acid to prevent cases like neural tube defects, congenital heart diseases, central line defects, so that it can prevent the development of those things. So we give them folic acid. Then we treat malaria. Like that is why there's this monthly use of Progranil or anti-malaria.
So what's the question?
So my question is that you said they are not modifiable.
Yeah.
So I want to be sure, this is Canada, and I want to be sure if they are not modifiable.
Yeah, I think you are talking in the context of Africa, right? But in Canada, no patient who is pregnant is given anti-malaria prophylaxis, right? For example, in Canada, we encourage patients to take folic acid at times as part of. In fact, there's a lecture in our course. We have a lecture on prenatal because there's a whole objective on prenatal stuff. In Canada, almost all these cereals and the rest are fortified with iron and folic acid. Number two, in Canada, we encourage that before the patient gets pregnant, if they plan on getting pregnant, 2 to 3 months before they get pregnant, they should start taking folic acid. So I understand what you're talking about, because I also trained under the same circumstances. However, in Canada, like the issue of anti-malaria treatment or anti-malaria prophylaxis will not suffice. But we encourage the patients to take folic acid. However, there are people who take folic acid who still have babies who develop gastroschisis and omphalocele. Most of the time, these central line defects, we are most of the time talking about neural tube defects like prosencephaly, anencephaly, spina bifida occulta, those ones, rather than the gastroschisis and the omphalocele alone. So that's something you want to pay a little more attention to. So that's why at times I'll suggest that, think like a Canadian physician.